Okay, we're back from that small break. Again, thank you for tuning in tonight. I'm Dr. Michael Reiner, your host of the show, The Independent Doctors of Pahrump, and we've been talking about chronic obstructive pulmonary disease tonight, and we've been showing some slides and some pictures of what that might look like and how that disease model takes place, and trying to break that away from a little bit of the restrictive lung disease, which is the other side of that, and talking about its effects on the population and how severe it is. And one of the things I like to talk about is about getting into your doctor and getting a spirometry done or a breathing test done. If you've had a history of smoking, even as little as 5 to 10 years, there's probably a decent chance you might have a little bit of COPD. And I do see people that have smoked their entire life that come in and get a breathing test, and I mean, there's absolutely no damage to their lungs. Totally defies logic, totally defies medicine, but that's less than 1% of the people that are out there. Most of the people who have smoked for multiple years will indeed develop chronic obstructive pulmonary disease. And there are some conditions, and I should mention that, an alpha-1 antitrypsin deficiency. I know that's a big word, and I just kind of threw that over your head, but it is a rare genetic disorder where you do not have to smoke, and yet you can develop emphysema. And that is a condition that can be tested for, and certainly it is a genetic disorder. So alpha-1 antitrypsin deficiency is a cause for emphysema, and you would never even have to smoke. And there's a simple screening test that can be done for that to see if that is in your genetic makeup. With that being said, and excluding that rare disorder, most of the obstructive lung disease that we see today is basically due to continued smoking and inhalation of noxious substances. So again, getting into your doctor and getting that spirometry test done can actually prevent a lot of the disease from taking hold as we get older. We naturally lose lung tissue as we age. We may develop it at a maximum of age 25, and I have a slide to try and describe that for you. But the earlier you can get treatment on chronic obstructive pulmonary disease, the earlier and the better you will do later in life. And you know, there's multiple areas where you can help defend against that. Certainly one of the callers, we talked on an earlier show about the pneumonia vaccine, and I've talked about this. If you're in the age of 60 to 65, I definitely would get the pneumonia vaccine. I know they've, a couple of patients have asked me about that new one called Prevnar. I don't know that's any different from the other one, but on the other hand, once you get past the age of 65 to 70, you're unlikely to be able to process a lot of the vaccines that are out there because your immune system just can't make new antibodies, and that could be part of the reason we see a lot of cancers and things as we tend to age, because our immune system doesn't hold up. But I'm digressing off to a different subject from COPD. Anyway, there's another slide, if we can go to that. It shows a little bit about the severity of chronic obstructive pulmonary disease. Breaks it down into mild, moderate, severe, and very severe. And this is based on what we talked about in the FEV1, or the forced expiratory volume in the first second. So if you went into your doctor and you wanted to be screened for COPD, and he did this particular test on you, and he came back and said your FEV1 was 85%, then you were normal. If he came in and said you're at 70 to 80%, then you might have mild obstructive pulmonary disease. Remember, this is that you're trapping 25% of the air in your lung. You're maybe not going to expand those balloons. It may not be an issue, but certainly it might be, and deserves close follow-up. If you're falling into that 60 to 69 area, then treatment might be necessary to prevent further progression of that disease. And that doesn't mean oxygen. Oxygen is not really indicated as a treatment for COPD until the late phases of chronic obstructive pulmonary disease, not even in the early phases. In fact, if you were at 60 to 69%, you probably wouldn't even notice anything. You'd be out doing all the activities that you normally would do. You'd be able to do everything that you're going to want to do during the day, and you probably would never ever experience it. When you get down into the 50 to 59% of the moderate to severe COPD, you'll definitely notice some symptoms. Maybe at the end of the day, meaning a little more fatigued and more difficulty with keeping up with your chores. Maybe more short of breath with a little bit of walking. Maybe you could walk 250 feet, or you could, walk a couple of miles. Now into the 50 to 59%, you maybe have to walk a mile before you get a little out of breath. And certainly in the severe COPD, 35 to 49%, you're having a lot of symptoms. You can barely do what you need to be able to do. You might even need oxygen, and when you're at 35% or less, you are hospice appropriate. That means the average life expectancy of someone with very severe COPD could be the possibility of you dying from that disease in 6 months or less. So take heed, get this stuff tested, and get stuff looked at before you do that. So I like this slide because this is St. Bartholomew's down in the Caribbean, and that's a very short runway of about 2,000 feet, and the planes come in. They do an amazing job of landing in that small runway, and you can see in the distance that beautiful blue water. So. And I don't know how these people do it, but they sit on the beach at the end of the runway, and that would be not my favorite spot to suntan, wondering if a plane would not make it on the edge of the runway. Anyway, this is a slide that I talked about earlier about your lung capacity as you tend to, basically, as we get older, the yellow line, we reach a maximum lung capacity in the age of 25. And then over time, the top arrow would be your natural decline in that lung volume. Obviously, you have infections, you get bronchitis, you get colds, maybe you get exposed to dust, maybe you get exposed. So these are just the natural things that cause our lung volume to decrease. And then all of a sudden, you see this sharp dip, like where you start smoking and you accelerate the loss of that lung tissue. That line that comes sharply down off of the first red line, it would show you the slope or the rate at which you're losing that lung tissue. And then all of a sudden it goes equal or parallel to the line above it. So what would that mean? Well, if you stopped smoking at that point, then you would regain the normal loss of your lung tissue, meaning you would resume the natural or the, the normal loss of that tissue, even though you will never make up the difference that you lost as a result of the smoking or that insult. So obviously, the reason we treat COPD or to reduce the mortality, which is the death due to that. And the number one thing, and the number one cause is obviously stop smoking. Supplemental oxygen in the late phases of this disease are very, very important to prevent further destruction. Not in the early stages, but one of the things I do in my office is we like to test people that basically maybe have a history of smoking but are on certain medications, and I've talked about it before. It's sleep apnea. We talk a lot about reducing the amount of desaturation at night. Just because you have sleep apnea or obstructive apnea, sometimes you might need oxygen also. So you should have an overnight pulse ox done, even if you use CPAP, to make sure that you are actually getting the oxygen into your lung. So we talked about other COPD treatments, bronchodilators, anticholinergics, cortisone-based products, antibiotics, vaccines. We already talked about vaccines, and we talked a little bit about maybe reducing some of that stress in your lungs and things of that nature. So let's go on, and we'll talk about some of the agents that we use. Albuterol is one of those things that people use all the time. You'll see them. It's the stuff that's in the nebulizer. It's called what they call a beta agonist. It basically opens up your lungs. So let's talk a little bit about what that means. Inside your lung tissue, you have what they call beta and your heart tissue has beta blocker. So if you take a beta blocker, the beta blocker will slow your heart rate down, but beta agonist actually can stimulate your heart. So when you have, but they also open your lung tissue. So obviously it's an opposite effect. If we give someone beta agonist to help open up their lungs, we stimulate their heart. For certain people that have heart conditions, it's very difficult to treat them with beta blockers. So let's suppose you have a atrial abnormality which causes your heart to speed up. If that happens, you wouldn't want to take a beta blocker if you had COPD, because that would help to close your lungs down. So fortunately, science created a drug that helps you avert that, and it's basically and I know this is very complicated, but it's basically a left side mirror of albuterol, and it's very good for those people who have heart conditions. In fact, I see this a lot in COPD, where the heart only fills during rest. So if we increase the rate at which your heart is beating, we reduce the amount of blood that can actually get inside your heart to be pumped out. Meaning if your heart beats 60 times a minute, imagine that it's beating and it can open up. How much blood can fill in during that time? If it's beating really fast, you're not going to get much blood in there. So let's take someone who's short of breath and their heart's beating very rapidly. What are they going to do? They're going to go take their albuterol. They're going to take a puff off their puffer. What's that going to do? Stimulate their heart rate even faster. They're going to feel more short of breath. So this levoisomer, L-isomer of albuterol, Xopenex, is very, very useful for those people who have a heart condition. And if your doctor hasn't prescribed you or talked to you about it and you do have a heart condition and a lung condition, that's the medication you would want to be on to help prevent a rapid heartbeat, especially if you're short of breath. So I have a lot of patients that have to be placed on that. It's obviously pretty new on the market, pretty expensive, but very, very important. And so again, people will do that with a nebulizer. You'll see them using the puff stuff that they they call it a peace pipe, and that's a very useful thing, but it obviously, because it's a liquid, it causes a lot of stimulation of the heart. Anyway, we're going to go to break, and when we come back, we're going to finish up a little talk about treatment. And again, thank you for tuning in tonight.